Jasmine, on the table, we're gonna flex the headpiece about 10 to 15 degrees. Is that okay with you?
Mm-hmm.
Now remember, everything is to patient comfort though, so if that were not comfortable for her, we could bring it up. But that's just kind of the standard that we're gonna start with. We would pull the T-bar out until the patient's elbows are at about 150 degrees. We didn't really have to pull it out too much here. If that's really uncomfortable for her, I might just have her hold on to the armrest. Is that better for you?
No, yeah.
You good? Well, you might till the table's going too. So, but normally you would always hold on to the armrest, and that's what you're gonna need to do for the practical. We are gonna have a skeleton, so you'll just have to verbalize that part. 10 to 15 degrees flexion in the headpiece. We've got the abdominal piece dropped out. You would not drop that out if your patient had a spondylohyperlordosis or facet syndrome, or if they just didn't like it. We wouldn't drop that out. Let me have you scoot. You're right about good. Got her ASI assist positioned right here. We're gonna get her in just a little slight plantar flexion. And I think we're good to go here. You do want the table height at an appropriate working height, so you don't have to bend over too much, or don't have the table too high up here. So I want this so that when I'm doing stretches, I can just lean into my contact. Whoa, you didn't recheck the table.
Yeah.
So be sure not to drop the table. Remember, you're just gonna have a skeleton on it, so you really shouldn't be letting the table fall. If you let the table fall with a skeleton, imagine what would happen if you had a patient on the table. All right, we're gonna start the table, Jasmine. There we go. You are right there? Is that comfortable? All right, so for the occipital stretch, I'm just gonna use my thenar on the base of the occiput, and I'm gonna lift cephalically as the table flexes. So as the table flexes here, I'm gonna lift on her occiput. I'm not gonna hold that pressure the whole time, only as the table flexes. As the table comes back up, I'm gonna release that pressure. So I'm just gonna hold. Do that about 6, 7, 8 times, depends if it feels really good to your patient. You are getting some positive Y distraction down the whole spine. Infusing those joints with synovial fluid, so that's really good for her whole spine, whether that's her symptomatic area or not. So there's occipital. Then we would do a sacrothoracic. So I'm going to contact the sacral base here, and we're going to do 6 spots, 2 upper, 2 middle, and 2 lower thoracics. As the table flexes, I'm pushing superiorly with my cephalic hand and inferiorly with my caudal hand that's on the sacral base. You really only have to show me the 6 spots, but of course, if your patient had an area where you felt a little bit more, then you could kind of focus it, right? So there's sacrothoracic. Then we do iliothoracic. For the iliothoracic, I'm gonna have the iliac crest right here in this part of my hand. Now remember, for a lot of people, I see a lot of times, and you've probably at least had it done to you, when somebody goes to find your iliac crest and they're too what? They tend to go too low, right? They don't come up high enough. So if I'm looking for the iliac crest, why not err on the side of caution? I'm gonna come up here by our ribs and then come down, and now I know I'm right on top of the crest. It's right here, it's right here. And then I can come around. So iliothoracic, there I'm on her ilium, and I'm just gonna do 6 spots again when I'm stretching the left ilium, and again 6 spots stretching the right ilium. We're gonna have to turn this table up because it's kind of slow. It's a little tight in there. There we go, and here, there we are. 1, 2, 3, 3 on the left. Good. And again, I'm pushing P to A. I'm pushing I to S with my cephalic hand and S to I with my caudal hand. So there was lateral sacrothoracic. Then we can do rotation. I'm sorry, that was lateral iliothoracic. That was iliothoracic. All right, so let's recap since I said that wrong 3 times. This was the occipital stretch, right? Sacrothoracic, we have a hand on the sacrum and we do the 6 spots on the thoracics. Then we do iliothoracic, where we would stretch with hand on the right ilium, do all 6 spots, and then left ilium, do all 6 spots, or it doesn't matter if it's left or right first. Then we can do rotation sacrothoracic. Well, I can stay over here, but everybody else is over there. So
I'll switch. We can switch.
Rotation sacrothoracic is just like sacrothoracic, except for we're going to have her turn her head now. Turn your head to the left, please. And again, just like sacrothoracic, except for that her head is turned. And turn your head to the left, please.
To the right?
Yeah, that one. To the right, the other left. Notice the hand position too. We're not going to be like this or like this. You can just bring your hand across. It's really easy to stretch this way. All right, so occipital sacrothoracic, iliothoracic, rotation sacrothoracic. Do you remember what comes next?
Lateral?
Yep, goes back down. Lateral sacrothoracic. So I'm going to flex the patient away from me. This time I'm only going to stretch 3 spots in the thoracics because we're stretching, and that's the only side that's stretched. So lateral sacrothoracic, again, sacral base, 3 spots on the left side. Is that right? Laterally flex the patient. And then I could go to the other side and do the right lateral sacrothoracic, or I could drop down to one knee to get the 45-degree angle for lateral iliocostal. And I'm going to be on the iliac crest and just do kind of upper, lower, and middle and lower ribs. So that was just to be more efficient. So I'm going to come over here. I did not do the right lateral sacrothoracic yet. So there's my right lateral sacrothoracic. And then here is my right iliocostal. Good. And I think we have one more left. Is that right? So we did occipital, we did sacrothoracic, we did iliothoracic, we did rotation sacrothoracic, we did lateral sacrothoracic, we did lateral iliocostal, and what's the last one?
Scapular.
Yep. Sacroscapular. So this one we're just going to kind of grab the inferior pole of the scapula and stretch with the sacral base. You're mostly just I to S, but if you had a specific restriction, you could work on that. But the main line of drive is I to S here and S to I on the sacral base. Now, if you have somebody with a basal anterior sacrum, you can see how all this pushing on the base might be uncomfortable. In that case, if it's really tender for your patient, just go down to the apex and use the apex to stretch, and you're going to be also mobilizing the sacrum posteriorly, and that would feel really good. So there's all of the stretches. Yes. So then we would go to CMAP, right? CMAP. For CMAP, you stand at the head of the table. Remember, MAP is motion assisted palpation. The MAA is motion assisted adjusting. So for CMAP, as the table flexes, these vertebrae should unimbricate from C7 going up. So like the picture up there on the board, the green.
I'll take a picture of
Straight
that.
behind you. Okay. Yeah. So that's that 45-degree angle of the facets. This is the 45-degree angle of the facets. So they're pointing kind of posterior, inferior, right? You're going posterior, inferior, 45 degrees. So we should feel those. We should feel C7 pop up as the table flexes, then C6, then C5, then C4, then C3, C2, C1. If 2 segments are stuck together, you'll get a little bit of a lag, and then they'll jump together. So let's say C7 pops up, C6 pops up, oh, C5 didn't just pop right up with the others. it waited a second, and then it moved as a unit with C4, right? So if you feel it more, when you feel them jump together, you'll feel them move more posterior because they're lagging until that next vertebrae comes and then they're moving. So we had there that C5, right, wouldn't glide posterior until it did, and then it did so more. So we're going to come in here and we need to monitor both sides at the same time. Oh my. And now I'm feeling it pop up more on the left. I'm sorry, her right, my left. I'm feeling it pop up more on her right. Right here. About C4. C4 is popping up more on the right. So that would be a C4 right posterior. So what it's doing, it's lagging, and then eventually when it comes back in a big motion. Moves posteriorly in a big motion. So anyway, we would palpate all the way up the cervicals looking for them to move together. If they pop up together, then we would have a posteriority at that segment, like that C4. If it's stuck posterior, it would have maybe a flexion restriction, correct? So C4 would be a flexion restriction, or you could call C5 a extension restriction. Most people don't really do that, but there is some talk. They're doing that. They do that more in the lumbars. Well, they'll go to the one below or the one above. And you know, when you're thinking about two segments and their relation to each other, so if I have a C2 left posterior, C3 is kind of right posterior in relation to it, right? That's a totally unrelated scenario to what we found here. And sometimes that can be important if you can't turn a patient's head one way. You can get a little bit of improvement between the joint motion between the two bones, possibly by moving the one underneath, so that now you have a decrease in symptomatology enough that you can move the one above. That can be the case sometimes as well. All right, so that's for cervicals. And then thoracics, remember, and when we found that, when we felt that abnormality, Leander called that a long axis fixation. What we're trying to feel for is normal long axis distraction. That's that LAD that you see in there. But if we don't feel normal long axis distraction, we're feeling a fixation, that would be a long axis fixation. So in the thoracics, he talks about those being primary and secondary. So primary would be your flexion restriction of the superior vertebrae of a two vertebrae complex. So as the table flexes, you're expecting the vertebrae to do this, correct? This is what they should be doing. So if you don't, or you could say the spinuses should be separating as the table flexes. So that's what you're gonna do. You're gonna come in and either monitor spinous tips or in the interspinous spaces, and you're feeling for that separation as the table flexes. If you find this is normal, long axis distraction, here we would have a long axis fixation between those two middle fingers. That would be a flexion restriction of the superior vertebrae and or an extension restriction of the inferior vertebrae. So we would come in here and palpate, kind of like being in the spaces. Okay, so she has like nothing between T1 and T2. It's like it's one bone. It's not moving. You feel that? Then it kind of moved a minute there. But we could come in and monitor several interspinous space. You got a lot of stuff locked up in here. So then we can find, these are not opening at all either.
Dang, Jasmine.
Huh?
I said, wow, Jasmine, she's just locked up. Huh?
She is, like every day, right? All right, so our primary fixation, we're gonna say we have a flexion restriction of T3. And so now what I need to see is if there's a secondary rotation restriction, right? So when I laterally flex to the left, which way should the spinous and the thoracics go?
Right.
To the right. I think it almost goes to the left. It like did nothing and then it went to the left. Did you feel that? All right, so if the spinous should go to the right, the vertebrae should be going into what kind of rotation? Right? When your ponytail goes to the right, which way does your face turn?
Left.
Left.
Exactly. So left rotation, correct? If the spinous, think your ponytail is being your spinous, right? If the spinous should have gone right, it should have gone into left rotation. So that'd be a left rotation restriction or an RP, which we could feel in here very definitely, and that would be our secondary restriction or fixation. Good? All right. Then we go to LMAP. And our timer runs out. All right, so then we go to LMAP. Very similar, when we were up here in thoracics, in the upper thoracics, you can laterally flex. I can also have her turn her head. So we would also expect the same thing, especially in upper thoracics, turn your head to the left. And it maybe goes to the right a little bit, but not much. Now in your book, I think it just talks about the rotation for thoracics, but you know, when you get below T7 or so, it's not really gonna so much work that way. You can go ahead and put it face down. Also, somewhere in here, your coupled motion is supposed to switch, right? So you might have to do a little bit more manual palpating in the lower thoracics. Because that transition point can be a little different from patient to patient. And I think that's why our research results for coupled motion don't have very much consistency. Not to mention the fact I'd love to see a coupled motion research study done on freshly adjusted patients who were determined to have normal coupled motion, right? For ones who had good movement in their lumbar spine, no pathology and that kind of thing. And adjust them first and then check them for which way things couple in a pain-free, healthy person. All right, so for lumbar again, we are looking for a long axis fixation, or we're feeling for normal long axis distraction. Long axis distraction is that normal separation of the inner spinous spaces. And this one's listed the same way as the thoracic. So we look for a primary first. So let's say we don't feel the L3-4 spinuses come apart. Then we would go ahead and go, say, to the L3 spinous. And as I left laterally flex the table, the spinous should go, it did not. Right, it should go left. So left lateral flexion in lumbars goes with right rotation. We had left lateral flexion with left rotation in upper thoracics, right? So here we had expected the spinous to go to the left, but it did not. So that must be a what kind of rotation restriction?
Right.
You can't do this. It's right rotation, right? Right? Your face turned right. Think about where your face goes. That's what you have to think about. Right? So if we laterally flex, the spinous doesn't go to the left. That means the vertebrae didn't go into right rotation. We then had a flexion restriction of that superior vertebrae. That was our primary. And then the secondary would have been a right rotation restriction, or an LD, if you wanted to name it that way, right? You're gonna show me how to adjust these two. We're gonna go ahead and go through how to do them all first, because we don't have a lot of time today, and I want you to practice. And the adjustments you've learned in like 85 different classes, right? So most of them are just like Thompson, you're gonna make your contact. I'm not super particular about the contact, more so about the biomechanics. So are you thrusting in the plane line of the disc? You're not on upper lumbars going this way, right? Against your listing, you're on the right side. Lumbars, I really like, if you're gonna use a drop, I really like Pisces over thumb is one of my favorites. I'll do pisiform over thumb, especially for L5. I feel like I can really get my thumb in there if I'm gonna use a drop. But sometimes when people are really tender, I'll use more of a Pisces hypothenar if I can get it in there, just because it's a little more comfortable, right? It's not such a pointed contact. There's also, and it's in Bergman and Peterson too, there's one that I really like for lumbars. You can actually grasp the ASIS, and you work on the contralateral side. And you can actually palpate this way too. It doesn't really work with flexion distraction so well. We can palpate and then adjust in that same position. You just don't lift the ASIS more than 2 inches. And anytime you're doing something like that or on a knee chest table, you gotta make sure that your HVLA definitely has the LA, the low amplitude. You're not gonna do a real deep thrust, or you could cause a hyperextension injury, which could result in something like a facet syndrome, right? So we don't wanna do that. In the thoracics, any of those, you could use bilateral thenar, you could use, a single hand contact. Like I said, any of those that you learned, as long as make sure you're adjusting in the proper table motion, proper line of drive, and it's a contact that makes sense. Not like yesterday in Diversified when they told me they were gonna use calcaneal on the left apex. Picture that. I'm like, your hand is over the entire sacrum. What are you doing? Yeah, that's a Pisces, or hypofemur, kind of knife edges contact, right? Okay, so that's lumbar. Then we're gonna go to sacrum. We're gonna go to sacrum. So as the table flexes, what is the sacrum doing?
Extended.
It's extending. If the sacrum does not, and you can actually palpate in the sacral sulci, right there in between the PSIS and the sacral base, to feel the sacral base extending. It should be extending as the table flexes. If the sacral base cannot extend as the table flexes, then we either have an extension restriction of the sacrum, which is actually a lumbosacral flexion restriction, because this is the table's lumbosacral flexion. So if the sacrum can't glide posterior on lumbosacral flexion, it's a lumbosacral flexion restriction with a decrease in posterior glide of the sacral base. Or you could call it an anterior inferior sacral base. You do need to understand the motion listings too, though. If we found an anterior inferior sacral base that couldn't glide posterior on table flexion, we would adjust by contacting the apex on table, boom, flexion. You can do that with or without a drop. As the table extends, the sacral base should do what? Yeah, it should flex, it should glide anterior. If the sacral base does not glide anterior on table extension, which is lumbosacral extension, we would have a lumbosacral extension restriction with a decrease in anterior glide of the sacral base. Or a posterior stuck sacral base. If the sacral base is stuck posterior or it can't glide anterior, we would contact the sacral base and go P to A on adjust extension. Because that's where the sacral base goes into that position the most. On that one, we talked about in Thompson, you learned this, right? And we talked about this, which is, I think the way most of us do it. So Thompson says, don't do this because of your fingers. Sorry, I adjust apex too, so I'm comfortable with being careful where my fingers are. You do have to be careful where your fingers are, it is important. So I get why they did that, or somebody did that at some point. But as long as if you know that you're like so in your head, you totally forget what your fingers are doing, you probably should do this. But I'll let that be up to you. And here, you've learned all this stuff, so biomechanics are good, then we're good. All right, so that's just the nodding of the sacrum, right? Then we talk about tilting. So for tilting, if we're gonna talk about movements about the left oblique axis, this is the left oblique axis, and axis is a fulcrum for motion, so that means that the right base and left apex pivot about the left oblique axis. So if we're gonna monitor the right sacral base, we should feel that right sacral base come posterior as the table flexes. We should feel it move anterior as the table extends, right? Then as we laterally flex, if I laterally flex towards me to the left, the right sacral base should do what? Fall in the hole, right? It should move anteriorly. It should move anteriorly. If the right sacral base doesn't move anteriorly on left lateral flexion, then maybe it's stuck posteriorly, right? So we could have a right posterior superior sacral base. Or if the right sacral base can't move anteriorly, we could have a right sacroiliac flexion restriction with a decrease in the anterior glide of the right sacral base. Correct? So those would be our listings. We'll come back and talk about how to adjust all those kind of all together at once. Then as I right laterally flex, that right sacral base should come posterior. If the right sacral base can't glide posterior on that right lateral flexion, then it could be stuck anterior, or it could just be that we have a right sacroiliac extension restriction with a decrease in posterior glide of the right sacral base. But if it's stuck anterior or it can't glide posterior, we would make the right sacral base glide posteriorly, or correct that anterior misalignment, by contacting the left apex, correct? And when does the sacral base move posterior? On table what?
Flexion.
Flexion. So we would adjust there on flexion. And we can go ahead and leave the table laterally flexed. Good. or you can do side posture, although remember in clinic, they don't really like the side posture with Leander technique because it doesn't take the technique, I don't know, all the benefits of the technique. But when you get into practice, you don't have to be a technique purist. Very, very few docs out there are. All right, so that was right sacral base. Then we can look at the left base and the right apex, how they move. The left base and right apex both move about the right oblique axis. That would be the fulcrum for their motion, or the axis of rotation. Remember, when structures move about an axis, think about a kid on a gymnastics bar. The thing rotating around the axis is actually perpendicular to it typically. So we're going to monitor the left sacral base. I can left laterally, actually I'll go ahead and right laterally flex the table like we talked about. Think about the base falling into this crack in the table right here. Can you see the crack?
Yeah.
When I flex away, the sacral base should go anterior on the side of convexity here. So just think about the base falls into this little crack. Student came up with that. It's brilliant. So here, while monitoring the sacral sulcus, here's her PSIS. Here's the sacral base right in between the PSIS and the base. And remember, it's not after you move, it's as you move the table. It didn't really move very anterior. The sacral base should move anterior inferior on this side as I right laterally flex. If the left sacral base does not move anterior inferior as I right laterally flex the table, it could be stuck posterior on that side. Or it could just be a left sacroiliac flexion restriction, a left sacroiliac flexion restriction, right, with a decrease in anterior glide of the left sacral base. Right, and those are the possible listings. If the left sacral base is stuck posterior or it won't glide anterior, we're gonna go P to A on the sacral base on that side. Remember, it moves this way, so I'm actually gonna take my tissue pulling contact this way. And I'm gonna do that on extension here. Because the sacral base should glide anteriorly on table extension, right? Good. And then when I left laterally flex the table, the right, I did kind of move posteriorly there. The left sacral base should move posteriorly when I left laterally flex the table. So it moves posteriorly on that same side. If the left sacral base cannot move posteriorly when I left laterally flex the table, then it could be stuck anteriorly, or it's just a left sacroiliac extension restriction with a decrease in posterior glide of the left sacral base. If I have an anterior left sacral base or a decrease in posterior glide of the left sacral base, I can return it to neutral or induce posterior glide by contacting the opposite apex. So I would come here, tissue pull across to the right apex, and we would adjust on table flexion here. Good? Good, good. All right. The other thing too, I think we might have talked about a little bit to find the apex, just a kind of a little trick. Here are her PSISs. If I put my ring finger on the opposite on the opposite sacral base and make a chiro hand, there's her left apex. It's right there. So you kind of have to play with it. Everybody's hands are a little bit different size. Usually most people hit me right about here, in here, but I can feel it with that kind of side of my hand. This is also a fairly, it's not like a real personal thing, right? To come in here, it feels pretty professional, right? Because you're not doing all this. So it's good contact. All right, well, we made it through sacrum, and ilium's easy. Ilium's super easy. Ilium follows L5, which follows the table. So when the table flexes, the ilium should flex. When the table extends, the ilium should extend. So the ilium's pretty easy. So we can monitor again in the sacral sulcus, and you should feel this one's moving good. Can you feel that, Jasmine? This one doesn't want to glide forward. So the ilium, as the table flexes, the ilia should flex. as well. As the table extends, they should extend. So as the table flexes, I don't really feel this PSIS flexing or gliding anteriorly. So she might have a PI ilium on this side, or she could have just her ilium can't glide anterior. That would actually be a sacroiliac extension restriction with a decrease in anterior glide of the right ilium. So, and remind me in a second, there is a thing that has a summary on Blackboard with all of those restrictions and everything, if you need kind of a summary page to look at it and draw it out. And it has listings to static and dynamic on there. So if the ilium wouldn't glide forward or it were stuck posterior inferior, it should glide forward on table flexion. You would then make contact on the PSIS and adjust P to A, I to S on table flexion. If the ilium couldn't extend as the table extended, as the table comes up, then we would have a decrease in posterior glide of the ilium on that side, or you might have an AS ilium. It could be stuck anterior superior, or it could have a decrease in posterior glide. If that's the case, that the ilium can't glide, extend or glide posterior on table extension, then we would contact ish tube, right? Ish tube to adjust. We learned in Thompson to stabilize the opposite PSIS. You can also stabilize same side sacral base. But if you stabilize same side sacral base, remember you're probably not going to need a lot of force because you're actually thrusting in both directions and it's kind of a shearing motion, so it doesn't need a lot of force. I kind of think that Thompson probably came up with this stabilization because back when Thompson technique was, they came up with that, probably most of the chiros were bigger people, were big men who were probably more likely to put too much force in than otherwise. Now we're coming out with some of these that give us a little more leverage and a little more control there, but don't need as much force. So if you think about it, when I'm stabilizing, if I'm trying to adjust an AS ilium or a decrease in posterior glide, my stabilization, I'm trying to get motion in this left SI joint, right? Right? So if I'm trying to make this ilium move back, why couldn't I stabilize the base here? That's a direct stabilization, right? And then you can come in, you can come across this way or this way and adjust. You could, if it were just an AS, you could just stabilize the base. I would take my ish tube contact first and then stabilize the base and then thrust on the ish tube. If it were a posterior sacral base on that side, you could do just the opposite. You could stabilize, you could come in with your left base contact and ish tube. Actually, you need to be on the opposite side for that one. That's why I wanted to go like this, to get my line of drive. But we could do that here and stabilize right sacral base, thrust on the right ish tube. You see my line of drive is much better when I'm on the correct side. Or I could come in right sacral base, stabilize ish tube, and thrust on the right sacral base. And again, we do all those with the table movement. You can leave it in lateral flexion and everything to assist with the adjustment. Do you guys have any questions? You might want to put these just on the end. Those are the
Okay.
cards.